In some of the world's poorest nations, accessing healthcare is a struggle. Making well-informed decisions can determine if people live or die. Over the coming years, a new project will try to revolutionise the way health policy is made in Africa. Two hours' drive from the capital Kampala is the little health centre at Mathubire.
Malaria is the biggest problem here.
Most of the patients here today are seeking treatment for malaria, but the clinic has run out of anti-malarial drugs.
They have just gone out of stock. We had Coatem last month. It is just now 2 weeks back.
No ACT?
ICT we don't have.
Right.
We have been using Coatem. We have never got ICT.
ACT, or artemisinin-based combination therapy, is the anti-malarial treatment now recommended by the World Health Organization. It was adopted as malaria policy by the Ugandan government 5 years ago.
This was a very good policy based on very robust evidence. However, ACTs are fairly expensive compared to the traditional anti-malarials. So it's expensive for our governments to buy adequate amounts of ACTs for use at the health facility level.
The most important major problem we have is that we don't have laboratory tests. So we just diagnose symptomatical and we treat. We don't test blood here. We don't have a laboratory technician.
Malaria is endemic in Uganda. 6 million cases of the disease occur every year at an estimated cost of $658 billion. Every day, 320 Ugandans die from the disease. Most at risk are young children and pregnant women.
If I have malaria, I can vomit. I can't even walk. The legs might be stuck. I become too much sick. I start shaking and I can't eat.
Like most women in this ward, Isa has malaria and she's pregnant.
They say that if we don't treat ourselves earlier, we can lose our babies.
Isa was admitted to the Malago General Hospital 2 days ago.
I feel that, or maybe I will lose my baby or what.
Malaria is a big problem to these pregnant mothers because most of them are both early. Malaria can cause anemia in a pregnant mother. Unless she has got a baby who needs also blood from her. And this malaria can also cross the baby, which causes the baby also to die. With the power we have, we try all our best to treat the malaria, but still more and more come.
The Ugandan government recognises the toll malaria has on the country. It spends 10% of the health budget fighting the disease. And it's adopted comprehensive policies and strategies to try and prevent and treat it. In a Kampala slum, a volunteer health trainer encourages people to use bed nets to reduce the risk of being bitten by the malaria mosquito. Not everyone here uses a net. The government says it'll provide free bed nets impregnated with insecticide. Cost isn't the only factor determining whether people use bed nets.
Some people have used some of those nets for catching some of these little insects or even fishing in the lake here, or even for filtering certain local brew in some areas. So we need to find out why people really do that. And maybe when we come out, we can come out with the policies that now augment the uptake.
It's not only bed nets that are beyond the budgets of many Ugandans. So too are anti-malarials.
Kisinziira ku ssente ze tuba tulinawo, bakyayinza okuwa Panadol ne chloroquine, bakyayinza okuwa Fansida naye nga kisinziira ku ssente z'oba ogenze nazo. Kati era waba takugyeko musaayi, clinics ezo ezitajjaako musaayi kebera. Gwe kati omugamba nti kino kyekinnuma ye eddagala lyakola ki? Lyakuwa. So singa ate aba akugyeko amanya eddagala ki lyaba alina okuwa ettuufu erisobola omusujja ogwo.
Many Ugandans don't visit a health clinic when they have malaria. Traditional herbal remedies, healers, even spiritualists are often relied on for malaria treatment.
This is aloe vera plant. Some people use it to cure malaria. They cook it and they drink.
We still have communities which believe if a child got malaria fever and it started convulsing, if it convulsed, they may think that actually it's witchcraft. So we need to find out why they still believe that.
What is your blood group? Never bothered. We have been using this malaria medication for over 10 years. We are so sure of it that we have even instituted a system of no money back guarantee. We have had cases of people having malaria for years and for more than 15 years to 20 years, using this for only 1 month, and malaria is gone forever.
Uganda has the political will, the money and the clinical capacity to combat malaria. But there is much still to understand to effectively implement anti-malarial strategies on a national scale.
Why does the population choose first to go to traditional healers? Why don't people want to go to the health facilities? Perhaps they're too far away. If a health center is more than 5 kilometers away, this is a long distance. Even if it's close by, but there is nobody staffing or manning it, this is a problem. If there is someone staffing or manning it, but there are no drugs or there is no equipment to actually deliver healthcare interventions, this of course is going to be a problem. So it forces the community to turn to other solutions, including traditional healers.
These are just some of the issues identified as priorities by the SURE project in Uganda. SURE supports the use of research evidence to better inform decisions about Africa's health systems. The project will collaborate with and strengthen existing networks now working in Africa.
Research would help to highlight these gaps in the existing health systems, having pointed that out and then trying to find ways of overcoming these gaps so that we constantly have research produced that is relevant.
This is an acute care children's ward in a Kampala hospital. Half the children here have malaria. Uganda is currently considering the drug Fansida to prevent malaria in children under 5.
A lot of research has been done in the region that shows that if intermittent treatment with antimalarials is given to children, this can contribute a lot in reducing the malaria burden.
But for a malaria prevention policy like this to work, there needs to be a plan for how Fansida will be delivered.
Who is going to deliver these interventions? Do we have enough health personnel? Do we have enough nurses or doctors or community health workers? And to find if our national budget can actually support an intervention, because no matter how good a policy may be, if you cannot actually implement it on the ground, then you're not solving the problem.
We must line up our areas of research in terms of priority. Otherwise, if we just come out, if somebody comes out with a research question which is not very relevant, we shall miss the boat.
Over the coming years, researchers and policymakers in Uganda will work together to find better ways to use evidence to fight malaria and strengthen the country's health system. At stake is an opportunity to overcome diseases that devastate the country.
We have the hope of getting rid of malaria in this country. malaria is a disease you can eradicate, you can eliminate, because other countries have done it. All we need is just working together to dent a disease that has been dented elsewhere in the world.